I'm Stephen Morrissey, Managing Editor of the New England Journal of Medicine, and I'm talking with Joseph Newhouse, a professor of health policy and management at Harvard Medical School and the Harvard School of Public Health, and a professor at Harvard's Kennedy School of Government. Professor Newhouse has co-authored a perspective article on new findings regarding geographic variation in Medicare expenditures. Professor Newhouse, you chair an Institute of Medicine committee that was asked to study geographic variation in Medicare spending to help determine whether to adjust Medicare's provider payments on the basis of a value index. Why was that study undertaken, and what would you say is the most important take-home message?
This study came out of the 2010 debate over the Affordable Care Act, and it stemmed from the well-known variations that the researchers at Dartmouth have publicized in the Dartmouth Atlas. Members of Congress from low-spending districts made the case that their areas, or many of them, gave what they thought was good value to Medicare, but they didn't get paid as much as other areas. So they proposed that there be a value index, which would in some fashion account for the value of care that was given as well as the cost of that care. And if the value was high, that the reimbursement to the area would increase. And as part of the negotiations over the reform bill, the Department of Health and Human Services agreed to fund a study to be carried out by the Institute of Medicine that would examine this concept and make a recommendation about it. Now, our major finding, or one of them, was that areas don't make decisions. Physicians and other entities such as hospitals make decisions about clinical care. And we feel that incentives need to be directed at the entities that make those decisions rather than at areas.
There's been considerable debate over whether variations in Medicare spending reflect differences in aggressiveness of care or differences in the health status of the patients. In your view, is aggressiveness of care the culprit?
Well, they are certainly one factor, but we don't think they are the only factor. One of our findings was that much of the variation across areas is attributable to differences in post-acute care. That's primarily home health services and skilled nursing services, along with some other services such as rehabilitation and long-term care hospitals and hospice. And that could be attributed to the aggressiveness of post-acute providers, but usually when people talk about aggressiveness of treatment, they have in mind decision-making by physicians. And this may reflect more passivity by physicians than aggressiveness.
So is it worth asking if physicians in some areas are more aggressive in delivering care? How do they get that way?
Well, I'm not a physician, so I would certainly be speculating. My guess is that certain norms of how cases are treated are established in a region, and how they're established, I don't know, but they seem to persist. I do remember even when I was a graduate student, it was well known that there were large differences in length of hospital stays between the East Coast and the West Coast, and those seem to persist year after year. And I don't know if that would be called differences in aggressiveness or different degrees of conservatism or what, but they seem to be there.
You mentioned that post-acute care spending is one of the major drivers of overall Medicare spending. Why do you think that post-acute care spending is so much more variable than other forms of spending?
Well, if you look at post-acute care spending by area, some of the differences are truly large and very suggestive to me of fraud. We know that there have been convictions of criminal gang figures for identity theft, and much of this turns up in post-acute care. How much of it is attributable to fraud, no one knows, but it is certainly a major contributor to the variation that we observe.
You say that regions don't spend. And in fact, you found in your study that there was quite a bit of variation within hospital referral regions, either by hospital service area, which is a subunit of the region, or by specialty. Was that a surprising finding?
I don't think so. My whole reading of the literature is that there's literally variation under every rock that one turns up in this domain.
And you argued in your report that variation within regions makes it unfair to apply the same Medicare payment adjustment to an entire hospital referral region. Would targeting Medicare adjustments to what you call clinical decision-making units be one of the committee's recommendations? And if so, how would that work?
I can't really talk about recommendations yet because the committee hasn't voted, and the interim report contains no recommendations. We'll be issuing a final report this summer that will contain recommendations. But by decision-making units, we do have in mind such things as accountable care organizations, the value-based purchasing arrangements that Medicare has put in place with hospitals and physicians, and Medicare Advantage plans.
Do you think that financial incentives do work to change provider behavior?
We know financial incentives affect provider behavior. They're certainly not the only determinant of provider behavior, and they're probably not even the most important determinant of provider behavior, but they are the major policy lever that Medicare has to affect outcomes. And it's natural that the Congress would look to payment, I think, to try to affect provider behavior.
And finally, do the findings of your study change the way we should think about geographic variation?
I like to think that they shouldn't change how we think about it in an important way. I think what they should do is try to change the framing of how we think about variation away from a geographic area to variation across physicians and other persons who are actually making decisions that affect the variation.
Thank you, Professor Newhouse.